This is Kristen Stavingas, and I'm going to be discussing our chapter, Management of Head Injury, Special Considerations in Children. The objectives for our chapter include the following. Pediatric traumatic brain injury is a leading cause of disability in the United States. Management of pediatric head injury requires understanding of the neurologic development unique to this population. Initial trauma resuscitation includes physiologic stabilization with special attention to age-dependent oxygen and volume status. If abusive head trauma is suspected, patients should undergo a comprehensive evaluation for additional systemic injuries in addition to a Child Protective Services referral. Routine CT scans are not indicated in children with mild injury and no evidence of clinical decline. United States law mandates that all youth athletes must be removed from play if concussion is suspected and may not return to play unless cleared by a medical professional. The biomechanical properties of pediatric bone allow for certain skull fractures which are unique to this population. Children are more susceptible to changes in carbon dioxide levels, and alterations in autoregulation are frequently seen in pediatric head trauma. Pediatric patients have a pre-existing lower seizure threshold and thus are at an increased risk of post-traumatic seizure activity. There is no strong evidence to support the use of therapeutic. In the pediatric population, traumatic brain injury is the leading cause of morbidity and mortality in the United States. According to the Centers for Disease Control and Prevention, TBI causes nearly 500,000 emergency department visits and more than 2,000 deaths per year. Expanded media coverage, political legislation, and recognition of TBI by professional sports organizations could all be factors contributing to the heightened awareness. However, despite increased prevention and educational efforts, pediatric TBI continues to rise, largely due to the recognition of mild TBI and concussion. The specific management of these patients is distinct from that of adult patients because of different physiology in these age groups. The observed types of TBI and mechanisms of injury differ with child age and development. According to the CDC, falls are the most common mechanism for TBI in children ages 1 through 4. As they reach school age, head injuries are frequently due to the increasing mobility of the child and need for transportation. Sports-related head injuries, a rapidly expanding field of current research, also emerge in this age range and represent a unique type of repetitive mild injury that can have devastating cumulative effects. In adolescence, the incidence of automobile-related head injuries increases dramatically and represents the most common cause of death, with a 5-fold increase in death rate for patients between the ages of 15 and 19. The clinical presentation of head injury in the pediatric population is largely dependent on the severity and variability of the initial trauma. Due to the unique age-specific biomechanical properties of pediatric neuroanatomy, children are susceptible to a wide spectrum of injuries, many of which are rare among adults. Children are more susceptible to traumatic brain injury because they have a larger head-to-body size ratio, thinner cranial bones providing less protection, less myelinated neural tissue, which makes them more vulnerable to damage, and a greater incidence of diffuse injury and cerebral edema when compared to adults. One important characteristic of the pediatric patient is the dramatic change in circulating blood volume with age. Hypotension tolerable in normal children may cause harm in a child with TBI. At the same time, high blood pressure can lead to unnecessary bleeding as well as brain swelling if autoregulation is impaired. Advanced Trauma Life Support, or ATLS guidelines, provide a structured, systematic approach for the emergency care of pediatric trauma patients. The initial evaluation of patients who have sustained severe head injury is based on physiologic stabilization rather than targeted diagnosis-based therapy. Evaluation of airway, breathing, and circulation precede the neurologic evaluation, and their stabilization takes priority. Although airway and breathing management is typically similar to that in adults, evaluation of circulatory status and blood loss can be quite different. Fluid resuscitation in the pediatric population should be physiology-driven while still respecting the age-related differences within this population, keeping in mind that excessive fluid may actually be harmful. According to the pediatric guidelines, resuscitation should proceed as in the highlighted algorithm. When evaluating for a source of hemorrhage, in children it's important to keep in mind that head trauma itself can be a source of significant blood loss. Although at times trivial in adults, blood loss from scalp lacerations and hematomas can be a significant portion of blood volume in a child. Furthermore, head injury in an infant with open sutures can expand the cranial vault and mask a significant amount of internal bleeding. After initial resuscitation and stabilization of the severe trauma patient, detailed neurologic examination can be undertaken. Standard cervical spine precautions should be maintained for patients in whom head injury is suspected. Important aspects of the primary survey in all suspected head injury patients include inspection for scalp hematomas or lacerations, palpable skull fractures or evidence of basilar skull fractures, and focal neurologic signs. In infants, a bulging fontanelle may be indicative of elevated intracranial pressure. The Glasgow Coma Scale is a useful tool for older children and has been modified for younger children. Head injuries can be classified generally into mild, moderate, and severe after initial resuscitation. Some group patients with GCS scores of 14 to 15 in a separate category from those with GCS scores of 13 because the management is distinct in terms of initial workup and imaging. Mild head injuries are the most common, yet despite the recent recognition of TBI as a public health concern, they are still believed to be vastly underreported. A subset of mild head injuries is classified as concussion, defined by a rapid onset, transient, neurologic impairment that resolves without intervention. It is thought that these symptoms are due to a transient disturbance in function rather than a true structural injury. Commonly, patients will experience a loss of consciousness, disorientation, headaches, amnesia, and sleep disturbance. By convention, concussion is not associated with any imaging findings on CT scans. Although in general, 5% of patients with mild TBI do have a finding on CT, such as a skull fracture or an intracranial abnormality. Patients with concussion and a CT finding are classified as having a complicated mild TBI. Achievement of optimal outcomes starts with appropriate initial evaluation and assessment of the type and severity of neurologic injury. Although determining when to image patients with moderate to severe head injuries is less controversial, there is debate about whether patients who present with mild head trauma warrant imaging. In studies of patients with a GCS score of 14 or 15 and no focal findings, CT scans revealed a clinically significant finding in only about 1% of the patients. If these cases are further stratified to patients with normal mental status, no scalp hematomas, no loss of consciousness, no clinical evidence of skull fractures, and a low-risk mechanism of trauma, the chances of having a clinically significant finding on CT drops to anywhere from 0.05 to 0.2%. This set of guidelines for when to obtain CT imaging defined by the Pediatric Emergency Care Applied Research Network has been subsequently validated by other groups as an efficient and useful way to identify patients who should and should not undergo radiographic evaluation. This clinical decision tool has been validated numerous times by external studies and has repeatedly been shown to have a sensitivity nearing 100% for clinically significant TBI when the stratified factors are taken into account. The Canadian Assessment of Tomography for Childhood Head Injury Rule is another clinical decision tool for pediatric head traumas. The high risk factors were 100% sensitive for predicting the need for neurologic intervention, defined as any of the following within 7 days: death from head injury, craniotomy, elevation of skull fracture, monitoring of intracranial pressure, or intubation after head injury. The presence of any of the risk factors were 98.1% sensitive for the prediction of a brain injury on CT. According to the 2016 update of the American Academy of Pediatrics Choosing Wisely campaign, clinical observation is an effective alternative to CT imaging in children with a minor head trauma. If there is any suspicion of injury that may lead to further decline, patients should be admitted for observation. For those who do not have any of these risk factors, routine observation for anywhere from 6 to 8 hours in the emergency department is adequate to ensure that the patient remains intact without post-concussive symptoms and is able to tolerate diet without emesis. Routine repeat CT scans are not indicated in children with mild injury and no evidence of clinical decline. These patients may be discharged home and instructed to follow up with a qualified provider. Concussion can often be evaluated outside of an emergency department setting, either in the field or in an outpatient setting after the initial injury. After a diagnosis of concussion is confirmed, in the first hours of injury, the patient should not be left alone in case of neurologic decline. If the injury occurred in the setting of a sports event, the patient should not return to play because same-day return to play is associated with delayed onset of neurologic symptoms and worse post-concussive outcomes. A second injury in the post-concussive period puts the patient at risk for something called second impact syndrome, whereby a mild second head injury with close proximity in time to the first injury can trigger much more severe repercussions than two isolated head injuries that are separated in time. The most severe cases of second impact syndrome have been reported with sudden collapse, pupillary dilation, loss of eye movement, respiratory failure, and even death. The severe effects of second impact syndrome are often attributed to the sudden loss of vascular autoregulation with rapid elevation in intracranial pressure. Nearly 1/3 of pediatric patients have been found to have alterations in vascular autoregulation after head injury. To help guide medical professionals assessing these patients, there have been many postulated ways to grade concussions and different recommendations for return to play. Several concussion grading systems are outlined in this table with their recommendations for return to play. In general, most recommend an assessment of severity of the concussion based on duration and type of mental status change, including amnestic symptoms and loss of consciousness. Most agree with a graduated return to play strategy whereby activities are gradually increased in a stepwise fashion if the patient remains asymptomatic. If symptoms occur, then the patient needs to step down to a previous level activity until the symptoms resolve. As many as 39% of severe TBIs are associated with other traumatic injuries, so initial management relies primarily on resuscitation efforts as outlined earlier. In the most severe TBI cases, the decision to proceed with surgery often carries a high probability of an unfavorable outcome. Physiologically, in this population, hemostasis from the scalp flap is particularly important because it can be a significant source of blood loss during surgery. Other surgical indications may include complex skull fractures, cerebral spinal fluid leaks, or gross contamination. Urgent surgical intervention should be considered in cases of elevated ICP due to diffuse swelling and/or an intracranial mass lesion. The primary focus of neurocritical care of TBI patients is centered on preventing intracranial hypertension. Cerebral perfusion pressure, or CPP, likely provides the best guidance for ICP management in infants and children. CPP is calculated by subtracting ICP from the mean arterial pressure. In correlative studies, young patients 2 to 6 years old have the best outcomes when their CPP is maintained in the 40 to 50 range, whereas children 7 to 16 years old have the best outcomes when their CPP is from 50 to 60. To attain these ICP and CPP goals, several strategies can be employed. A tiered management strategy is depicted in this figure. If ICP remains elevated with basic maneuvers, second-tier management strategies with CSF drainage, sedation, and pain control, as well as hyperosmolar therapy can be used. If ICP remains refractory, the third-tier management strategies include consideration of decompressive craniectomy, barbiturate coma, hypothermia, and short-term hyperventilation. Of note, steroids, which are commonly used in other situations in which there is concern for elevated ICP owing to vasogenic edema, in the case of brain tumors, are contraindicated in trauma. Studies have shown that steroids confer no improvement in outcomes following traumatic brain injury, but do increase general rates of infection. Determining which patients will benefit from a decompressive craniectomy for the treatment of elevated ICP in the absence of a focal hematoma is more controversial. It is well known that decompression can reduce ICP significantly. However, some argue that patients who develop diffuse brain edema are so severely injured that expected outcomes are poor regardless of decompression. Decompressive craniectomies carry the risk of additional morbidity, including intraoperative blood loss, development of hygromas, hydrocephalus, and resorption of the reimplanted bone after cranioplasty. It is important to note that therapeutic hypothermia received much research attention after an initial pediatric study demonstrated improved outcomes compared with historical controls. However, several subsequent studies have failed to demonstrate overall benefit. Although ICP may improve, overall outcome can include increased mortality and worse functional outcome because of other factors associated with hypothermia, such as increased coagulopathy, cardiovascular problems, and hemodynamic instability. In a review of 7 randomized controlled trials, mortality and arrhythmia were increased in the hypothermic cohort. At this time, there is no strong evidence to support the use of therapeutic hypothermia in pediatric traumatic brain injury. Much attention recently has been given to previously unrecognized cognitive and psychological sequelae of isolated mild TBI, and especially repeated mild TBI or concussions. Concussion typically results in short-lived, transient neurologic impairment which resolves spontaneously. However, approximately 25 to 35% of children may experience physical, cognitive, emotional, or behavioral post-concussive symptoms. Even in isolated mild TBI with no CT findings, quality of life 1 year after the original injury can be diminished in as many as 10% of pediatric patients. In adolescents, there is a 2-fold increased risk for developing a new mood disorder in the 5 years following a TBI. With advancements in neurocritical care, overall outcomes for children with moderate and severe TBI continue to improve, the latest studies reporting less than 25% mortality. With rehabilitation efforts, the greatest functional improvements are observed in basic activity participation, while communication and independent self-care are the last and least likely to recover. Specific knowledge of how the pediatric brain responds to trauma and understanding differences in physiology are key to optimizing overall outcomes.